welcome on the behalf of Pakistan Society of Internal Medicine in a parallel session in the Hall B. We start our session right on 2:30. First, I request our chair, Professor Taj. He is the Professor of Medicine at Sharif Medical and Dental College at the Sharif Medical City. He is the renowned endocrinologist and diabetologist, and he is also a very active member of Pakistan Society of Internal Medicine. Our second chair is Dr. Ahmed Shehzad. He is the president, Lyallpur Diabetic Foundation, Faisalabad. He is also president, Punjab chapter, Primary Care Diabetes and Care Association. I welcome chairs. Now our first talk is about the insulin, and our presenter is Professor Dr. Aamir Shaukat. He is the Pro Vice Chancellor, Faisalabad Medical University, and also Dean Postgraduate Medical Science. He is also Dean Medicine Department, Allied, DHQ, Ghulamdabad. He is also Vice President, Pakistan Society of Internal Medicine. I welcome Professor Dr. Aamir Shaukat.
Bismillahirrahmanirrahim. Thank you very much, Dr. Irfan Saab, for your very kind words and kind introduction. I'm extremely thankful to be here and on the invitation of Pakistan Society of Internal Medicine. I can see many dear friends of mine sitting here, Professor Taj Sahib, Dr. Ahmed Shehzad Saab, Professor Zaman Sheikh Saab, and many dear colleagues of mine. Dr. Zulfikar Saab has travelled all the way from UAE and he's here. He is a very important member of Pakistan Society of Internal Medicine. So I represent Faisalabad Medical University. Faisalabad Medical University is a tertiary care setup. We've got 3 tertiary care setup hospitals associated with Faisalabad Medical University. You all will be very pleasantly surprised and happy to know that one of the fastest growing universities of Punjab is Faisalabad Medical University. We've got approximately 2,500 bedded Allied Hospital 1 affiliated with us. We've got approximately 1,500 bedded Allied 2 hospital affiliated with us, and a 3rd tertiary care hospital by the name of Faisalabad Teaching Hospital. We more or less offer all types of postgraduate courses at Faisalabad Medical University, including MPhil, PhD, MD, MS, and one of the recent additions to the feather of Faisalabad Medical University is the first of its kind level 2 diploma course known as Diabetes Diploma in Diabetology. And we are probably the first university in a public sector setup who's come up with diploma in diabetology in Punjab at least. The topic assigned to me is basically switching smart, the role of high quality insulin in improving diabetes outcomes. This presentation has been prepared in collaboration with Sami Pharmaceuticals. Majority of the slides in my presentation have been taken from the 11th edition of Diabetes Atlas. We know, unfortunately, there's a pandemic of diabetes all over the world. Approximately 600 million people in the world are suffering from diabetes mellitus, which is a dilemma. And out of all of them, the major part or burden is being borne by Pakistan. You can see here is that as far as the number of people with diabetes in the context of the country or territory is concerned, by 2024, Pakistan was ranked amongst the top 4, which is supposedly going to go up to, in 2050, up to number 3. So you can see as far as the age standardized diabetes prevalence is concerned, Pakistan is now ranked the number 1 country in the world to have maximum diabetic patients. So we are now the capital of diabetes of the world. The ADA guidelines has given us a sort of a change over the time. Now it's a decision cycle for person-centered glycemic management in type 2 diabetes mellitus, and the various points that need to be considered, which have been sort of to be considered in these guidelines, include the review and agreement on the management plan, provide ongoing support and management, implement management plan, assess key person characteristics, consider person-specific factors that impact choice of treatment, utilize shared decision making to create a management plan, and then in the end agree on the management plan and specify the SMART goals, which should be specific. Number 2, measurable. Number 3, achievable. Number 4, realistic. And number 5, time tested. And in the end, the goal of care is to prevent the complications of diabetes and optimize the quality of life. This is our basic goal, and all these guidelines over the years, they come basically to the crux of this matter. Diabetes, unfortunately, it is a disease that affects every part of the body. We all know it's got microvascular and macrovascular complications affecting the brain, eye, tooth, heart, vessels, etc. and etc. The reduction in diabetes complication is going to be manageable or only implementable based on these 4 or 5 things, which include glycemic control. Number 2, the blood pressure management, lipid management, and agents that should be prioritized with cardiovascular and kidney benefit. And in the end, it is basically a multi-centric sort of an approach, including lifestyle modification and diabetes education. Control of HbA1c still remains to be the hallmark of diabetes mellitus control, and glycemic control should be the top priority in diabetes to prevent complications. Glycemic control remains the most important factor in reducing cardiovascular risk. So out of the systolic blood pressure, duration of diabetes, physical activity, atrial fibrillation, cholesterol, estimated GFR, HbA1c still is the number 1 factor as far as reducing the risk of cardiovascular disease is concerned. You can see in both these charts depicted here, the stroke level and the acute myocardial incidences in all patients improves as the HbA1c goes down. This is a very famous slide, has been presented many times, but is one of my favorites. Every 1% reduction in HbA1c reduces the risk of diabetes-related deaths by 21%, myocardial infarctions by 14%, microvascular complications by 37%, and amputations or death by 43%. ADA over the years has sort of prioritized the intervention in diabetes mellitus based on the atherosclerotic cardiovascular risks or high risks for these diseases: heart failure, stroke, TIA, and chronic kidney disease. We know as the inception or the incoming of SGLT2 inhibitors and GLP-1 receptor agonists, things have changed. And now on top of metformin, if your diabetes is not controlled, we would be sort of choosing one of these agents for controlling diabetes mellitus. But since I'll be talking about insulin, around 1 in 4 people with diabetes mellitus, it's a hard fact, take insulin. And why should the insulin be initiated? Because of this part. Insulin is necessary with people of diabetes mellitus because as the time goes on, so does the pancreatic function deteriorate, the beta cell preservation and the beta cell mass goes down, and unfortunately the part of the world that we belong to, when diabetes is diagnosed, already there is depletion of the beta cells of pancreas, and we know once the beta cells of pancreas have been exhausted, the only way of covering that part is basically insulin. But unfortunately, a lot of time is wasted before we start insulin, and that is why we want to sort of reassert a very previously known famous concept that insulin is necessary with people with diabetes mellitus. Progressive loss is also a very famous slide. In type 2 diabetes mellitus over time, there is a progressive loss of insulin secretion with increasing insulin resistance, and as can be seen here, that as the insulin resistance goes up, so does the insulin secretion goes down, and which affects the fasting and postprandial control. Insulin use is often delayed despite poor glycemic control. Unfortunately, a lot of years have passed by before we start thinking about insulin. I basically also belong to that group in which we say that insulin should be at the last resort of therapy since the inception of GLP-1 receptor agonists and SGLT2 inhibitors, but still insulin should be kept in mind once you know that the A1C has gone very high and the beta cell mass of pancreas is exhausted, because you should not be wasting time of those patients in which the HbA1c is very, very high and they've exhausted the reserve of beta cells. Poor glycemic control in type 2 diabetes mellitus in Pakistan, you can see poor glycemic controls prevails amongst diabetic patients ranging from 44.7% to 86.4%. And the barrier to insulin therapy is a part or a resistance on the part of the patient, including the concerns about weight gain and hypoglycemia, fear of injections, fear of caregivers, etc. and etc. But there's a big problem on the part of the healthcare provider as well. If you are not conceptually very clear about which part and time when the insulin should be initiated, then you are wasting your time and the time of your patient. The recommended glucose targets for patients in type 2 diabetes you are very well aware of. This is only a very simple sort of a slide given here, but the A1C should be less than 7. The efficacy of insulin on treatment of type 2 diabetes mellitus, out of all the agents available to date, the range of HbA1c reduction as a monotherapy is the best with insulin. This is a hard fact which cannot be denied. In Pakistan, access to insulin products in Pakistan, according to the various national surveys done, is a problem because of this is a survey based on the prices, availability, and affordability of patient. And you can see here that access to insulin products in Pakistan is very, very limited. And a lot of patients simply are denied the benefits of being earlier, in the early part, being on insulin only because of the fact that insulin availability is very, very poor. And economic burden growing at an alarming rate in Pakistan. 44% of the population, they live below the line of poverty. That is why my recommendation is starting a patient on insulin should be sort of thought about in the earlier part so as to sort of reverse the disease process. The 4 steps to insulin initiation. Step 1 to be considered is insulin appropriate. What are the physical and psychological barriers to treatment? What is the individual's lifestyle and commitment to self-management? What support is needed for the successful implementation of the chosen regimen? What does starting insulin mean to the patient? Obviously, these are the 4 or 5 things that need to be addressed. The fear of being on insulin, will it be painful? Social stigma, the needle itself plunging into my skin. These things are to be addressed by the healthcare provider. This hurdle exists, and this is a big change in the event in the life of a type 2 diabetic individual. That is why we need to sort of bring about a change in our thought process. The partnership of decision making is based on a collective relationship that you develop between the patient and the healthcare professional, which leads to an effective diabetes care. The different types of insulin regimen, only 3 or 4 slides on this matter. When trying to recreate the normal pattern of insulin secretion, different patients have different needs. Therefore, different regimens are available, which include sometimes you need 3 injections, sometimes you need 2 of them, and the type of insulin that needs to be given to patients also sort of should be conceptualized. The insulin treatment attempts to mimic the secretion of normal insulin pattern. We know it's a basal bolus combination. The bolus insulin is basically for the postprandial control, and the basal insulin is basically to maintain and control the fasting sugar levels. Now, if you've got an upsurge of the postprandial level, this is going to be controlled by the ultra short acting insulin, or for that matter by the regular insulin part. And if you want to control the fasting sugar level, it's going to be possible by the intermediate acting insulin or the ultra long acting insulin. So the insulin treatment attempts should be to mimic the normal pattern of insulin secretion as has been shown in this slide, which is shortly coming up. This is a short-lived, rapidly generated meal-related insulin peaks, and then you need to address the peaks of the sugar that go up and also to control the basal intermediary level insulins. So the basal bolus insulin physiology is what has been that I want to sort of discuss with you. Unfortunately, right. This is the basal bolus insulin physiology. You know the bolus one is the rapid acting Lispro and the short acting regular insulin, and the basal part is the intermediary acting one or the long acting one. Now the human insulin are the short acting regular insulins and the intermediary acting ones. The analogs ones are the rapid acting ones and the long acting ones. This we all know of. So basal bolus insulin physiology, if you want to control the breakfast insulin, it's going to be possible only by the bolus insulin. The lunchtime is also bolus, but the postprandial one is only be controlled by the ultra short acting insulin. So that is why, so as to conceptualize the concept of when to start the insulin is very, very important. So, it stopped working again. Right. The courtesy of the company that I'm here of is basically Semolin R. Semolin R is basically the short-acting regular insulin. It's absorbed quickly and lasts for several hours. The onset of action is 30 minutes. It's the basically human insulin, the regular short one. The intermediary N1 is the N-pitch insulin, which is absorbed slowly, and the onset of action is approximately 90 minutes. And the max event you achieve in 4 to 12 hours. And the pre-mixed 70-30 Semolin one is a biphasic human insulin, mixture of short and intermediary acting insulin, and the maximum effect is from 2 to 8 hours. This pre-mixed insulin is to be given twice daily in combination with the DPP-4 inhibitor, metformin, or whatever you choose is better for the patient. Starting insulin dose units is a very difficult point which majority of our PGRs and the junior doctors don't understand, but the general formula is 0.5 units per kilogram for pre-mixed insulin, and calculate the daily dose based on this formula in a 60 kilogram man. The pre-mixed insulin is to be divided into 3, that is 2/3 dose in the morning and 1/3 dose in the evening. This is a general formula that we did, but obviously needs to be individualized according to the patient's sugar levels. But support is required throughout the treatment, which means you need to be in touch with the patient, address his needs, so as to know about his control of the fasting and the random levels, and to conceptualize is basically to understand that which insulin is meant for the control of the fasting sugar levels and which one is basically meant for the control of the postprandial upsurge that is expected to happen. So conclusion is, preventing complications is one of the 2 goals of diabetes management. Glycemic control is an important pillar in preventing complications. Insulin therapy remains to be an important treatment in diabetes. Good quality human insulins can help control diabetes and reduce cost at the same time. Remember, diabetes is a marathon, not a sprint. In a matter of style, swim with the current. In a matter of principle, stand like a rock. You know, we are at Faisalabad Medical University, we've collaborated with Chinese diabetologists recently, and very shortly you'll be hearing very good news that we are opening up a diabetes center in collaboration with Government of China at Faisalabad Medical University, in collaboration with Lalpur Diabetes Foundation. Dr. M.S. is here. So very soon this project is coming up. I'm extremely thankful to my mentor and teacher, Professor Javed Akram Saab. I've been his student ever since I was in 3rd year in King Edward Medical College, and it's my honor and proud distinction to be present here. Unfortunately, he's not here, but I would have loved him. It's always a pleasure being in his company. This is a glimpse taken from Faisalabad Medical University when the Chinese team was here, and we are singing the national anthem with the Chinese delegation that visited us, and we are very soon going to be coming up with this diabetes center at Faisalabad. किसी को ये मैंने शेर जावेद अकरम साहब को डेडिकेट करना था और कर रहा हूँ. किसी को बेसबब शोहरत नहीं मिलती है ए वहीद, उन्हीं के नाम हैं दुनिया में जिनके काम अच्छे हैं. This is a 50 years commemoration stamp of Punjab Medical College and a wellness tract that we've just developed at our university. Thank you very much for being a beautiful and wonderful audience. Thank you.
Thank you, sir, for a very comprehensive presentation on the insulin. Remember, he is a person behind the postgraduate degrees which happened in the Faisalabad Medical University. No, I'm really feel apology and my sincere apology to the Professor Ziaullah Khan. He is there, he will chair this session. Professor Ziaullah Khan is the Professor of Medicine at the Sir Syed Institute of Diabetes and Endocrinology. He is the Fellow Royal College of Physicians, London. Sir, please take your seats.